Good afternoon, everyone, and welcome to the STI Expert Hour webinar, Results of the Anchor Study and Their Implications for Anal Cancer Prevention Guidelines with Doctors Christina Brickman and Joel Pilevsky. I'll give it one more moment for people to join. Welcome. Good afternoon, everybody, and welcome to, good morning, everyone, and welcome to the STI Expert Hour webinar, Results of the Anchor Study and Their Implications for Anal Cancer Prevention Guidelines. My name is Dr. Rosalind Platzker, clinical faculty with the California Prevention Training Center. I'll be emceeing today's webinar and going over some introductory slides. I'll be going off camera now, but we'll continue to give you the introductory slides. Next slide, please. So, a little bit more about the California Prevention Training Center first. The California PTC is a multidisciplinary training center and capacity building assistance center. STI clinical training is sponsored by the CDC, and we are a member of the National Network of STD Clinical Prevention Training Centers, or NNPTC. STI clinical training provides virtual and in-person training events, technical assistance, clinical tools, and STI clinical consultation services focusing on complex STI issues in patient care. You can learn more about STI clinical training at CAPTC and the NNPTC by visiting the web pages listed on the slide. Next slide, please. The CAPTC also runs the STD Clinical Consultation Network, or STD-CCN, for our region. This is an online clinical consultation network where providers can submit complex STI questions and a subject matter expert will reply either by phone or email per your request within 1 to 5 business days. Next, please. Next slide, please. Thanks. Here is our financial disclosure. We have nothing to disclose. Next slide. Here's our CME disclosure stating that today's webinar is offered at 1.25 units. And here are the CME requirements for today's webinar. You have registered for the, back one slide, please. Thank you. You have registered for the webinar on NNPTC by the deadline, and please note that registration is now closed. You attend the webinar live and in full. Attendance recorded as you sign on to the webinar. Unfortunately, we cannot give partial credit or credit for viewing the webinar recording. And finally, you complete the post-course survey evaluation by July 7th, 2023. Registrants will receive the link to the post-course survey evaluation within 24 hours after the webinar in the email notification from training@nnptc.org. The email notification is sent to the email address you use to register with for the webinar on NNPTC. To ensure you receive the notification, please add training@nnptc.org to your safe or trusted senders list, and be sure to check your spam or junk folders if you do not see the email in your inbox. Next slide, please. Email notifications. The post-webinar materials notification will be sent within 2 weeks after the webinar. Registrants will receive an email notification from captc@ucsf.edu with links to the webinar recording, handout, and any other available materials. You do not need to request these materials separately. To ensure you receive the notification, please add captc@ucsf.edu to your safe or trusted senders list, and be sure to check your spam or junk folders if you do not see the email in your inbox. If you meet CME requirements, you will receive the CME notification on or before August 21st from captc@ucsf.edu with the link to claim your certificate through our CME provider, which is the University of Nevada, Reno School of Medicine, or UNR. The notification is sent to the email address you use to register with for the webinar on NNPTC. And so to ensure that you receive the notification, once again, please add captc@ucsf.edu to your safe or trusted senders list, and be sure to check your spam and junk folders if you do not see the email in your inbox. Next slide, please. Finally, a few quick housekeeping notes about Zoom. Q&A will be turned on for attendees. Microphone, video, and chat will be turned off for attendees. Only presenters will have access to microphone and video. To use Q&A, click on the Q&A icon as seen here on the slide, which will be in the bottom of your Zoom screen. Once you click on the Q&A icon, you can type in your question and click send to submit. If you want to send anonymously, then you select anonymous. You can submit questions up to the last 2 minutes of the Q&A section. Also, during the webinar, I'll be reviewing Q&A and may answer your questions directly, or they may be answered live during the Q&A session. You can also submit your administrative questions to the Q&A, and they will be answered by our clinical admin team, Elizabeth Olson and Lauren Blackley. Next, please, if you have any questions, you can reach out to Elizabeth Olson, who is the CAPTC Clinical Program Manager. Her email address is shown here, elizabeth.olson@ucsf.edu. And now, I would like to introduce our speakers for today's webinar, Drs. Christina Brickman and Joel Pilevsky. Dr. Christina Brickman is Associate Professor of Clinical Medicine and Infectious Diseases at the University of California, San Francisco School of Medicine. Christina's clinical education and research interests are focused on the prevention of anal cancer. She is Associate Medical Director of the UCSF Anal Neoplasia Clinic Research and Education, or ANCHOR Center, at the UCSF Cancer Center, as well as the local site PI, or Principal Investigator, of the Anal Cancer HSIL Outcomes Research, or ANCHOR study, a national multi-center randomized controlled study that established the efficacy of treating anal cancer precursor lesions in preventing anal cancer. Christina is board certified is a board certified member, Christina is a board member of the International Anal Neoplasia Society, or EANS, and the director of the EANS Virtual Standard and Advanced High Resolution Anoscopy courses. Next slide, please. Dr. Joel Pilevsky is a professor of medicine and infectious diseases at the University of California, San Francisco School of Medicine. He is an internationally recognized expert on the molecular biology, treatment, pathogenesis, and natural history of anogenital human papillomavirus infections, or HPV infections, particularly in the setting of HIV infection. He is the founder and director of the world's first clinic devoted to prevention of anal cancer, the ANCHOR Center at UCSF Cancer Center. He is the vice chair of the National Cancer Institute, or NCI, supported AIDS Malignancy Consortium, and he is the chair of the ANCHOR study, which is, as I mentioned, a national multi-site study that showed that treatment of anal cancer precursor lesions prevents the development of anal cancer. He is founder and past president of the International Anal Neoplasia Society, or EANS, and is past president of the International Papillomavirus Society. He is founder and director of the International Papillomavirus Society International HPV Awareness Day campaign. And with that, it is my great privilege to hand the slides over to Dr. Brickman, and thank you both so much for being here.
Thank you, Roz. Give me 1 second while I share my slides with everyone. All right. Thank you so much for that introduction, Roz. I think what she did not mention is that she's also our colleague over at ANCHOR, and so it's great to have her introducing us, and it's an honor to be here. So I have no disclosures. In terms of the talk today, we wanted to give everyone an idea of who is at high risk for anal cancer, and also explain our approach to preventing anal cancer, primarily focused on secondary prevention, and explaining what we do at our clinic. And I was going to focus on the first part of that, and then Dr. Pilevsky is going to take on going over the ANCHOR study and what the implications are in the field of anal cancer prevention. So anal cancer arises from the most distal portion of the digestive tract. And 90% of anal cancers are associated with persistent infection with human papillomavirus, or HPV. They are primarily squamous cell carcinomas, and the strongest association is with HPV-16. And this is in comparison to, for example, cervical cancer, where about 50% of cervical cancers are associated with HPV-16. In anal cancer, it is by far the great majority of them are associated with this type. So here on the right side, I have a little depiction of the anal canal. And so you have the rectum, and where the columnar epithelium transitions to squamous epithelium is the squamocolumnar junction, which for us is where the anal canal starts. The perianus is basically what is on the outside and what you can see with gentle retraction of the buttocks. And the perianal cancers are also HPV associated and treated similar to anal cancers. And for the purpose of this talk, we often use anal cancer to mean both anal canal cancers and the perianus. Before I go on, I wanted to talk a little bit about the language that I will be using. You know, here at UCSF, there's been more and more of an attempt to try to use language that is gender inclusive, and that often means trying to separate anatomical structure from gender in our medical language. However, many of the studies have not incorporated this yet, and so a lot of what I will be showing older language to describe gender, and so I wanted to acknowledge that limitation before I proceeded. So this is an older slide on the incidence of anal cancer over time. And on the x-axis, we see year of diagnosis. And on the y-axis, we see the age-adjusted incidence rate per 100,000 person years. Blue is men and pink is women. And you can see that the incidence is higher in women compared with men in the general population. And so the incidence rate is quite low. Just to give you a sense of things, you know, colon cancer, maybe the incidence rate is about 30 per 100,000 person years. But you can see that there's been a steady increase from 1975 to 2009. And this increase is ongoing and is about almost like 3% per year, which is quite high. This next slide shows the trends in incidence of anal cancer according to age. And so I wanted to point out a couple of things. You know, we have men on the left and women on the right. On the x-axis, again, we have year of diagnosis. And on the y-axis, we have our incidence per 100,000 person years. And so, you know, similar to the previous slide, you can see that overall, we have had more diagnoses of anal cancer, more incidence as time has gone by. And I'm not sure whether you can see all the different age groupings, but basically the incidence is quite low in people under 40. And then it jumps as people get older. And this is particularly marked in women, especially women age 60 to 69 or above 70, where the increase has been of up to 5.3% per year. So general population, the incidence is going up, and particularly so in older patients, especially women. 1 second. So what are the risk factors for anal cancer? So they are the factors associated with HPV acquisition. And so this means multiple sexual partners, a history of anal condylomata or warts, a history of anal receptive intercourse, or a history of cervical, vulvar, vaginal, high-grade squamous intraepithelial lesions or cancer, tobacco. And then impaired cellular immunity is a strong risk factor for anal cancer. And this is best characterized in people living with HIV. So when studying incidence of anal cancer in people living with HIV, the way that this is done is to try to do this at a population level. And so, countries that have registries provides a great opportunity to get population level data. And what has traditionally been done is you take a cancer registry and you match it with an HIV registry, and this allows you to determine incidence rates for people. And so in the US, we have the HIV cancer match study. And this slide that I'm showing is actually from France. It's from the French hospital cohort. And actually studies, the results are fairly similar, but I like this slide. So I've now shown this many, many times. It's a little outdated, but I will go through it regardless. So on the x-axis, again, we have time, so the years and the incidence at that year. On the y-axis, we have the incidence rate. And then on the bottom, you can see the incidence rate in the general population. And again, similar to what I had shown earlier, these are quite low. But there is a really big jump in the incidence in people living with HIV. And you can see that the highest incidence rate is in men who have sex with men who are living with HIV, where there's almost like a, it's jumped to 95 per 100,000 person years. The rates are also higher in women living with HIV and in other men living with HIV. And so this slide, which in circles where people are studying, cancer epidemiology, has now been shown multiple times. So this slide is a meta-analysis conducted by Gary Clifford. And the attempt of this work was to try and compare the risk of anal cancer across different groups. And it's been proposed as a basis to identify people who are at high risk for anal cancer and who may benefit from screening. And so on the x-axis, we have different groups who may be at risk for anal cancer. And on the y-axis, we have incidence rates as determined by this meta-analysis. And so, once again, we see that people living with HIV, men who have sex with men who are living with HIV are our highest risk group, especially those above 60 years of age. But you can see other people who are at risk and who could potentially benefit from early detection of or prevention of anal cancer. Notably, women with a history of vulvar cancer or vulvar precancerous lesions, or women who have had solid organ transplants, so that's SOTR here on the slide, and who are a long time away from their transplants are also appear to be at quite high risk for anal cancer. So we have a rising incidence of anal cancer, and we have particular groups that are at high risk for this. Why else might we want to avoid anal cancer? 50% of the cases in the general population present with localized disease, and we have fairly high survival rates when patients present with localized disease. However, you do see a significant decrease in survival with advanced disease. And, the standard of treatment is chemotherapy and radiation for the majority of anal cancers. And there's substantial morbidity associated with this. And so, it would be great if we could find a way to prevent this. There exist similarities between cervical and anal cancer, and much of the rationale for anal cancer prevention rises from the cervical cancer model. So both are caused by persistent infection with human papillomavirus, and both have the same precursor lesion, high-grade squamous intraepithelial lesion, or HSIL. So this, I want to just point out this terminology. When we say this, we are referring to precancerous lesions of the anal canal. Cervical cancer screening programs have been available since the 1940s, and they center on the early detection and treatment of cervical cancer. And there's been dramatic reductions in the incidence of cervical cancer in countries where these screening programs exist. So the question is, can we apply the same concept to anal cancer prevention? And so this is where high resolution anoscopy comes in. So in the cervical cancer model, the patient undergoes a screening test, and that screening test may be a cervical cytology or it may be a cervical HPV test. And then when there are certain abnormalities, the patient is sent for colposcopy, which is basically a close-up exam of the cervix to identify areas of HSIL that can then be removed. And our program for high resolution anoscopy is analogous to us. Patients who have certain risk factors for anal cancer undergo screening by their primary care provider. And when that screening is abnormal, they are sent to us for HRA. And we actually have published standards on high resolution anoscopy, and we have a definition for it. So it is the examination of the anal canal and perianus using a colposcope for lighting and magnification after application of 5% acetic acid and Lugol's iodine solutions to identify lesions. And the whole basis of high resolution endoscopy is to really try and find these precancerous lesions so that we can figure out how to treat them. This is a setup. I forgot to mention, I will go back. So this is one of the nurse practitioners at our clinic, and this slide he knows that we share this slide frequently, but he's now becoming quite famous because we have shown this slide across many platforms at this point, but he's here performing high resolution anoscopy on a patient. And this is a setup for our room. So patients come in, this is a ambulatory procedure. The patient is awake, they're typically not sedated, and they lie on their side. At least at our clinic, they lie on their left side, although this can be done differently depending on the site. And you can see that we have our colposcope to perform the exam. And then on the right side, we have a tray for our materials. And we also have a screen because we take pictures. The camera has, the colposcope has a camera. And so we take pictures and we document our exams as we are doing the procedure. This is an example of how the tray would be set up. And so you see the anoscope, but we also have our vinegar solution. And we also have the iodine. And so both the vinegar and the iodine are designed to help us identify lesions during the exam. And here's a picture of what we see. So you remember I mentioned the squamocolumnar junction earlier. And so, pink in the middle is the rectum. So it's the end of the large intestine. And then this wider side at the periphery is the start of the squamous epithelium of the anal canal. And where they meet is the squamocolumnar junction. And it's actually where a lot of HSIL lesions originate. And it's where a lot of anal cancers will originate. And so our job as the person performing the HRA is to examine the entirety of the squamocolumnar junction and go around looking for lesions that might be consistent with HSIL. Let me just do this. And here's an example of a high-grade squamous intraepithelial lesion over here on the left side. And so to us, people who perform HRA, this looks classically like a precancerous lesion. It's aceto-white, it's lacy, it has some clustered glands, it has sort of faint punctation vascular changes. And then when we apply iodine, it does not pick up the stain. And so to us, this is an indication of something that we would want to biopsy to potentially treat down the line. Here's an example of, or here are two examples actually of anal cancer. Basically a couple of things I just wanted to point out is you can see that there's ulceration, that this is not a flat lesion. And anal cancer is often marked by ulceration as well as very atypical vascular. So these are all quite characteristic of anal cancers, and these are cases that we have encountered in patients in our clinic. And this is a picture of perianal cancer. And I like to point it out because we see a lot of patients who get misdiagnosed for having hemorrhoids. And so, it's important to look. And this is a very large lesion, but you can see ulceration, which is also classic for cancer, and this thickening at the borders, which is also very suspicious for an infectious process. So as I've mentioned, our objective is to identify and treat anal and perianal HSIL to prevent progression to invasive cancer. But we can also treat anal and perianal warts, which are also caused by HPV, but considered benign but bothersome. And so those are our low-grade squamous intraepithelial lesions. Treatment can involve multiple modalities, but we can often do it in the office, and it often involves ablation. And one of the main things that we do in our clinic is electrocautery. And so you can see here, we have a little machine that provides electrocautery, and we use a long tip in order to be able to reach into the anal canal and treat the lesions. And here is an example of somebody who had warts and who we performed electrocautery on. And so you can see that, as opposed to the cervix where concerning areas can be removed, we mostly try to burn things off and then allow them to heal. So it would make sense, that if somebody has a precancerous lesion, that we would go ahead and remove it, and that, we would be able to prevent anal cancer. But there are reasons to think the treatment might not work. One, it might just not be effective. Anal HSIL can be very difficult to eliminate. Sometimes patients have large multifocal lesions. High resolution anoscopy requires a fair amount of skill. And so, someone who isn't skilled may miss a lesion. And then new lesions, or what we call metachronous lesions, can arise over time. It also may not be necessary. Not all anal HSIL progresses to invasive cancer. And so there is the potential for overtreatment. And so because of the absence of this data, the anchor study was created to really try and determine whether what we are doing works in people living with HIV. And so with that, I will proceed to the next portion of the talk that Joel will take over. Thank you.
Thank you, Christina. I am going to share my slides. All right, so carrying on with the theme of anal cancer prevention, I'm going to be spending most of my time talking about the anchor study, but also wanted to talk a little bit about the role of HPV vaccination, since that constitutes what we would call primary prevention of anal cancer. These are my disclosures. And what I would like to do is talk about the results of the anchor study and their implication for secondary prevention, talk a little bit about vaccination, and describe the challenges that are going to come about as a result of new guidelines that we think will be put out very soon for anal cancer prevention. So Christina already introduced this slide, and I'm not going to go over it again, simply to point out that in the previous iteration, it lumps all HIV negative MSM together. And the risk is clearly elevated, but not terribly elevated. And what you notice is that the risk of anal cancer increases by age in virtually every one of these groups, with the exception of people who are immunosuppressed for reasons other than HIV. And here it's not age as much as it is years post-transplant or duration of immune suppression. But age is clearly important. And A recent variation of this particular graph actually breaks HIV negative MSM down into different age groups. And as we might have predicted, the risk does vary considerably by age here too. So the risk is quite low for HIV negative MSM under the age of 45 years. It's relatively high for the 45 to 59 age group, but clearly highest for those over 60 years of age. So I think this is important to keep in mind, because in terms of the denominator, the absolute number of HIV negative MSM, of course, is quite a bit higher than those living with HIV. So just a few words first about primary prevention, because in the long run, this is the absolute answer to prevention of all HPV-related cancers. If we could get everybody who is within vaccine age, ideally before initiation of sexual activity, to have been vaccinated, then over a period of time, and it might be a few decades, we would see the disappearance of HPV-related cancers. We all know that that isn't quite happening, that the uptake is variable for a variety of reasons. But in theory, HPV vaccination is the long-term answer to the problem. It's also the long-term answer to anal cancer prevention in addition to cervical cancer. And we showed a few years ago that the vaccine that had already been shown to be effective to prevent cervical HPV infection, high-grade CIN, and now more recently, actual reductions in cervical cancer, is also effective for prevention of anal HPV infection and anal high-grade disease. We haven't had enough time yet to see if there's an impact on anal cancer prevention. I do expect that will happen, probably will not happen for at least another 10 or 15 years, simply because of the time that it takes for the progression of high-grade disease to cancer. I also wanted to point out that there are a limited number of data showing that the vaccine is efficacious in people living with HIV, but there are data. This was an AMC study that we did in younger MSM living with HIV. We chose a younger population because we wanted to make sure that there were people who were still unexposed to the types in the vaccine, because these vaccines only prevent initial HPV infection. If you've already been exposed to that type, it's not going to prevent you from getting disease due to that type. And so we looked at a group of 16 to 26-year-olds. Most of them were in their early 20s. What was very disturbing, this was based in the US, was at the time that we screened them, already about a third of them had an anal high-grade lesion. And if you look at the proportion who are naive, meaning unexposed to the 4 types in the quadrivalent vaccine that was used at that time, you can see, for example, that HPV-16, the really bad HPV type, already about 45% of these individuals had been exposed to HPV-16 and more to the wart types. So what that means is that if we're going to vaccinate MSM, boys in general, MSM living with HIV, we really need to work on getting them vaccinated as early as possible, ideally within the target age range of 11 to 12, sometimes even earlier, but as early as possible prior to or after initiation of sexual activity. When we look at the endpoint of these studies, what you're looking for is a reduction in anal precancer or high-grade disease. And amongst those who were naive, who were theoretically going to respond to the vaccine, in fact, we saw no incident high-grade disease. For people who had already been exposed to HPV types, it was quite high. It was 14.6, quite a bit higher, in fact, than in the placebo group of the original phase 3 study. So the risk for people who've been exposed is quite high. If you can vaccinate early enough, there's a very good chance you'll prevent anal cancer in those groups. So now on to secondary prevention. That brings us to the anchor study, which Christina nicely introduced. It does mean something, this acronym. It's the Anal Cancer HSIL Outcomes Research Study. And this was a study of the NCI performed as a protocol of the AIDS Malignancy Consortium. you've already heard the punchline. You already know what the results are to some extent. The results were published about a year ago now in New England Journal, and did show that we did see a reduction in anal cancer in people who were treated for their anal HSIL compared with those who weren't. In addition to the main aim of determining whether treatment actually works, we had a few other aims. One was to look at the safety of the treatments that we were using for prevention, very important, to develop and implement a quality of life measure to see whether we were adversely impacting people through those treatments, and also to create a specimen bank that was going to allow us to study the molecular pathogenesis of progression from high-grade disease to cancer. So the study schema is shown here, and it's simplified, but we've studied people over the age of 35 who are living with HIV, and we screened them for anal HSIL because that was the primary study entrance criterion. When I say screening, I don't mean that in the traditional public health sense. I meant really screening for the study, because we used a technique that is the gold standard, but is not a screening technique, and that's high-resolution anoscopy, because we had to have biopsy-proven disease. If they had HSIL on biopsy and they met the other study criteria, we randomized them 50-50 to what we called active monitoring, meaning we followed them very carefully, but didn't intervene unless we thought they might have progressed to cancer, or they were randomized to treatment, in which case they were treated with the goal of trying to remove as much HSIL as possible, as quickly as possible. Okay, so if they had cancer at screening, of course, they were sent immediately for treatment of their cancer. And if we didn't find HSIL, they weren't enrolled in the study. Sometimes they were rescreened later to see if they might have developed HSIL, but basically people were randomized 50-50 to monitoring versus treatment. And then over time, we counted up the number of cases of cancer in both arms. Now, this is a big study, and we originally powered the study to give us an answer within a reasonable amount of time. And we projected that we would need 5,058 people with biopsy-proven high-grade disease to do that. As it turns out, one of our study assumptions turned out to be incorrect. Namely, our progression rate from high-grade disease to cancer in the monitoring arm turned out to be roughly twice what we thought it was going to be. As a result of that, we actually met our cancer case count earlier than projected and ended up stopping the study for efficacy before we even reached our enrollment goal. So although the study target was 5,058, we stopped the study at a time when we had enrolled and randomized and followed 4,446 people. To get those 4,446 people, we actually screened 10,723 people living with HIV. And I thought you'd be interested to see how much disease we found at screening, because this is kind of representative of what you're going to see in typical populations of people living with HIV. Quite strikingly, 53% of the men had anal HSIL on biopsy. 47% of the women had anal HSIL. Earlier studies suggested that women were at considerably lower risk of anal HSIL than the men. But in our study, the women were very close to the men as far as high prevalence of anal HSIL. And then the highest risk group of folks overall were transgender individuals, and 67% of those people had anal HSIL. So really high risk. When you screen more than 10,000 people, given what we understand about the prevalence and incidence of anal cancer, we were expecting to find anal cancers at screening, and in fact we did. We found 17 individuals who were basically asymptomatic at screening, and that translates into a point prevalence in the screening population of 160 per 100,000. So really high, because if you put this in context, the incidence of cervical cancer in a screened population in the US overall is on the order of about 8 per 100,000. If you look at the proportion of healthy women with high-grade CIN in the general population, it's probably less than 1%. And here we have a group of people who are hovering around 50% for a precancerous lesion. I want to say a few words about the demographics of the population in the anchor study so you can get a sense for how they might relate to the people who you see or take care of. The population overall actually pretty closely resembled that of the demographics of the overall US HIV population. The median age was 51. They were 17 years out after HIV diagnosis, and 80% identified as male, 16.5% as female, 3.1% as transgender. In terms of the racial ethnic background, 33% were non-Hispanic white, 42% were African American, about 16% were Hispanic non-African American, and 1.3% were Asian Pacific Islander. One area where we did differ some from the overall US HIV population was the higher proportion of people in our study who indicated that their HIV risk group was same-sex activity, about 78%. In the US overall, that's closer at this point to about 60%. 23% reported being heterosexual, 8% reported injection drug use. Unfortunately, a relatively high proportion of our population were smokers, about a third. And some people have said to me, well, with such a high prevalence of high-grade disease, their HIV disease must have been poorly controlled. That was absolutely not the case. If you look at the HIV viral loads at screening or randomization, rather, they were very well controlled. About 90% had either undetectable or very low HIV viral loads, and the median CD4 level at randomization was over 600. So this was a very well-controlled group with respect to HIV. We used two stratification factors at randomization. One was the nadir CD4, and as you can see, roughly half the group had a nadir below 200, and also the size of the lesion. We chose that because that is one of the main factors known to cause failure of prevention of cervical cancer. So if you treat a person with a cervix who's got a very large cervical lesion, that is the person who is most likely to fail and potentially progress to cancer. And we were concerned about the same thing in the anus. And so we divided the group into those with lesions greater than or less than 50% of the total mucosal and skin coverage of the canal and perianal region. And as you can see, about 13% had these very large lesions covering more than half of the area. As far as the treatment was concerned, Christina nicely talked about some of the treatments. The main one that we ended up using in the anchor study was electrocautery in the office. We wanted to standardize the treatment across the study, which was done in more than 17 locations around the US. So we gave clinicians a choice of treatments that they could use. And if they picked a particular treatment, they had to use a very strict treatment algorithm. Anchor was not designed to compare different treatments to each other. It was meant to compare a strategy to treat versus a strategy to follow. We were actually very lucky because almost everybody ended up picking office-based electrocautery as the treatment that was done. More than 86% of our participants had it, and most of them who had it had only that therapy. And so the benefits that we saw as a result of Anchor, we feel can be attributed to office-based hypercation. The results of the study are shown here. Basically, we saw a 57% reduction in anal cancer in the treatment arm compared with the monitoring arm. That was statistically significant. And you can see here the progression rates. So amongst those who were monitored, 400 or so per 100,000 person years was the progression rate from anal high-grade disease to cancer. In the treatment arm, it was obviously lower by a statistically significant amount. That number, 173, is a little bit higher than I would have liked. And so the message here is that treatment can absolutely reduce the risk of developing anal cancer amongst those with anal HSIL, but we still have some improvement possible as far as getting the progression rate amongst those who are treated down even further. This is the Kaplan-Meier curves showing the difference in the two arms between monitoring here and treatment, with progressive widening of the intervals. And the good news here is that the adverse events using this office-based bifurcation procedure that Christina described, the adverse event rate was very low. Amongst the many thousands of procedures that we did, we had only 7 study-related serious adverse events, and these resolved over a period of a few weeks. So the study was, this treatment methods were safe. Our quality of life assessment suggests, and these are data being prepared for publication, that also the impact on quality of life was quite negligible. Not surprisingly, we saw some reduction in quality of life in the few days or so after the procedure, but within a few weeks, almost everybody returned to their baseline. Now, I've alluded to the fact that size matters, and here you can see that one of the main risk factors for progression to cancer was the size of the lesion, where the hazard ratio was more than 5 when the lesion was big. We saw very high progression rates amongst those with the biggest lesions, and there are a number of possible reasons for that that perhaps we could discuss in the question and answer period. So I've mentioned that I wish we had even better results in the treatment arm, but I do want to put this into perspective too. Screening programs generally do not lead to complete reduction or elimination of cancer risk. Everybody knows that we do or are recommended to have a regular colonoscopy to prevent colorectal cancer. And in a publication a little while ago, a very large group of people who were followed when people had colonoscopy with polypectomies, there was a 67% reduction in colon cancer, so not 100%. And in the cervix, as I mentioned before, we also know that the risk of progression is higher amongst women who have larger lesions. I also thought I would put into context the number of cases that we need to screen to prevent a case of cancer. In the cervix, in the general population over a lifetime, that number is 1 in 2439. In the anchor study, to avert 12 cases, we treated 2,227 people, and that translates into needing to screen 375 people in order to prevent a case of anal cancer. Question, of course, is does screening for and treating anal HSIL meet current screening standards? And everybody is familiar with Wilson and Youngner. These were updated by Dobro et al. I'm not going to go into these in detail, simply to say that of the 12 principles of screening, we meet most of them, but not all of them. And some of them we meet partially, primarily because we don't have all the information yet. That includes the screening test performance characteristics. We're still working on those. And where we don't yet meet the criteria is existing infrastructure. Not surprising because this is such a new area. And we are in the process of trying to figure out how to set up the infrastructure that we think we're going to need. So the implications of the study findings are that the rates of progression from anal HSIL to cancer are very high. Treatment of anal HSIL is effective in reducing the incidence of anal cancer. And as a result of these data, the CDC guidelines for the care of people with HIV, which is the care of opportunistic infections in people living with HIV, are being revised. It's our expectation, this is not official yet, but it's our expectation that screening for and treating anal HSIL will become standard of care in people living with HIV. In addition, the U.S. Preventive Services Task Force has taken this topic on. They completed the first phase of information gathering and public comment at the end of January rather. So there's definitely room for improvement in the treatment of anal HSIL, and we also need biomarkers, because to have to treat half the population for HSIL is very challenging, and it would be extremely helpful if we knew which ones were more likely to progress or regress on their own. We have a hint already that size of the lesion matters, but we really need molecular markers, and that's what we're going to use the biorepository for. So assuming that screening and treatment become standard of care, I think that the next steps include scaling up HRA training programs. We have a serious shortage of people who are skilled in this technique, which takes a lot of time and dedication to get good at. Very rewarding. I encourage all of you who are listening today to consider doing this, but it does take some time. In the absence of full-scale screening and treatment programs, we believe that all people with HIV, particularly 35 and older, should have a digital anorectal exam to feel for hard masses that could indicate the presence of a cancer. If you do have the ability to do HRA and follow up on the results of positive screening tests, we recommend that MSM living with HIV and transgender people living with HIV start screening over 35, and the other groups over the age of 45. What does screening look like? Right now, people are using anal cytology primarily, which has some limitations. In all likelihood, we will end up with a combination of cytology and HPV co-testing when available. But in addition, you may want to consider triaging further, given limited capacity. And if I were to be asked which groups would I triage first, in addition to those who have abnormal cytology and HPV, particularly HPV-16, I would consider older people first, people who are smoking, and people who had very low CD4 naders. One of the reasons why we like electrocautery, as Christina mentioned, is that it's well tolerated. The machine shown here is relatively inexpensive if you're getting started buying new equipment, pretty reliable. It used to be a problem because in the past, there would be a lot of smoke generated by the electrocautery, and you'd have to have a person standing there with a vacuum hose, which was not convenient, but the tubing has improved, which allows for direct smoke evacuation at the point of the paddle. And so there's no more need to have a separate hose inserted. And so that really made life a lot easier. This is a technique that can be done by non-surgeons. Christina and I and Roz are not surgeons, but we all do this procedure without very much difficulty. It can be done in the office. Patients tolerate it well, doesn't take too long, doesn't require a lot of pain medication. So in summary, in the long term, HPV vaccination is the best way to reduce the incidence of anal cancer. That really means gender-neutral vaccination. Unfortunately, of course, millions of people will not be able to benefit from the vaccine, and so we have to have something for them. That's where secondary prevention comes in. Now we know that treating anal HSIL works, and so it will become standard of care for people living with HIV. For those of you thinking about new directions in your career, or those of you starting out thinking about something interesting and useful to do, this is a very exciting field, moving very quickly. A lot of work to do on optimizing screening algorithms, developing and evaluating biomarkers, evaluating new treatments, developing new algorithms for follow-up, training people, getting trained, lots and lots happening. So I'm sure any of us in the anchor group, Christina, Roz, or myself, would be very happy to talk to you about how you might get further involved. Thank you very much for your attendance. Sorry for the problem with the screen, but look forward to an interesting Q&A session.
Thank you so much, Dr. Polewski, and I love the plug for people to join us. It is a fascinating anal world. So we have a couple questions, and before I get started on those, I'm just going to pull up a screen that has a couple reminders about our webinar, because I know, there are always lots of logistics about CME that come up. So I'm just going to leave this here if I can. Can people see this, the CME and post-webinar materials? Okay, great. Okay, so one question that I think is a nice one to start out with for both of you is the role of IBD. One attendee asked, I'm surprised the risk scale did not include factors like Crohn's disease or ulcerative colitis. Did IBD or inflammatory bowel disease come up in your research for anal cancer?
Christina, why don't you go ahead?
Sure. So it actually is on the slide. It's I don't know that I can pull it up right now, but it is on the right side of it under other forms of immunosuppression. So I think they took people with IBD and assumed that they were on treatment that was causing immunosuppression, and there's not great data, but what we do have does suggest that the risk is higher, I believe, and I'll let Joel correct me, but I believe particularly in Crohn's disease, but I could be remembering that wrong.
Yeah, IBD is an interesting example of an area where we need more research, because it's a combination of potential pathologic processes going on at the level of the anus and anorectal junction due to the disease itself, and the treatment of the disease, where the immunosuppression that may or may not be given to the patient can also contribute to the development of disease. When all is said and done, you need to have HPV. I think HPV is going to be necessary, but insufficient. But HPV is also really, really common, even in people who haven't had anal intercourse. So IBD is a risk, and there is much more to learn about what's going on in that setting.
Great, thank you. And speaking of HPV, one question that just came in was, for those with detected high-risk HPV who go on to clear and who have not already been vaccinated, is there a role for vaccination regardless of age? And I think that this is a nice one to address. I know it's not directly related to anal cancer, but a lot of our attendees are a little further upstream in terms of this process. And so in terms of HPV vaccination, what do you think of someone who has a history of high-risk HPV? They seem to have cleared that high-risk HPV based on screening, and is it worth it for them to get vaccinated?
Christina?
Oh gosh, so I get to go first on this. I was like, I wonder what Joel's going to say. So, I feel like there have been a lot of studies, especially in the cervical world, trying to demonstrate that vaccinating after treatment or HSIL, or even after clearance, can help. Whenever I look it up, it seems unclear to me. What I will say, and I say it over and over again, it's really a vaccine that works when you have not been exposed. So I don't know how much benefit someone has if they've cleared their anal high risk infection and then they get vaccinated. There is this thought that people are constantly being re-exposed, but I don't really know that it works at that point. For me personally, when I discuss the vaccine with patients, especially because we tend to see, in our clinic, we see adults, right? So we see people who have already, many been exposed to HPV vaccination. I review the guidelines. I review that the vaccine is very, very, very safe. And we have a very, we have an excellent data to support that. And so, if someone's already been exposed to HPV-16, I don't, from an anal cancer prevention standpoint, I don't think there's much benefit. But it's not going to harm them. And where it might harm them, especially if they're outside of the age range where it's covered, is they may have to pay for it out of pocket. So that's how I think about the vaccine. Joel?
Well, I think about it a little differently, actually, because honestly, I would completely ignore the fact that this person had had HPV X and cleared it, because I think the way I think about it is the vaccine has 9 different HPV types in it. And there's a very good chance that regardless of prior history of having been exposed to this or that HPV type, that there's a possibility of protection against the types that the person has not yet encountered. So I think there is still potential benefit for protection against the HPV types in the vaccine they haven't met. So I tend to make my recommendation more based on age than on any history of either a lesion due to a given HPV type or knowledge of whether or not they've had this or that HPV type. What Christina is talking about is a different indication that people are thinking about when it comes to the benefit of the vaccine, and that is there some additional protection that occurs as a result of being treated for, say, a high-grade lesion, and then there's a reduced risk of a recurrence. There are some data suggesting that that happens, and that, in my mind, is an additional potential indication to give the vaccine to people in our clinic who we've been treating and who seem to have recurrence after recurrence. But the data are pretty soft. Overall, I think you should give the vaccine to people based primarily on their age, where everybody who's up 26 and under should get catch-up vaccination. And if they're up to age 45, the CDC guidelines are after a one-on-one conversation between the provider and the patient. And then I do exactly what Christina mentioned. I indicate that I don't know for sure what the benefit is, but it's safe. And more, actually, insurance companies are covering the cost for people at least 45 and under. But it is important to make sure that the patient checks so that they don't end up with a surprise that may be a financial hardship for them.
Thank you both so much.
Joel, oh wait, can I actually now I'm going to ask Joel a follow-up question, because I do think that's a really interesting question that was posed. Is there any evidence though to suggest that, like, if you vaccinate someone, that it prevents reinfection to someone that's already been infected with a certain type? I didn't think that was the case, but
no, I mean, there are a bunch of studies going on right now, for instance, like in the cervix, an AMC study, where women with proven HPV vaccination are getting see and treat for their high-grade cervical disease and getting vaccinated versus a placebo to see whether or not the risk of a recurrent lesion is lower. The thinking actually is that what you're really doing is preventing a lesion developing after exposure to a new HPV type, not the existing HPV type that caused the first lesion. But I guess it kind of doesn't matter. If you're preventing a high-grade lesion, you're preventing a high-grade lesion.
Yeah, and this also brings up another question, which I'm very curious, especially Dr. Polewski, after what you just said, what your thoughts are, which is about why doctors aren't recommending doing Gardasil 9 after someone has had the quadrivalent vaccine. So if there's someone who had the quadrivalent vaccine when they were younger, before the nonavalent was available, why not give them the nonavalent vaccine to protect them from those 5 additional strains? Is it worth it?
Yeah, that's a great question. The basic answer is, if you look at the accrued benefit from a public health point of view, it doesn't really pencil out from a cost benefit point of view. And that's because 16 and 18, which were in the quadrivalent vaccine, are still by far the real bad guys. So yes, you will prevent some additional high-grade disease related to the additional 5 oncogenic HPV types. And it's been shown that there's no safety issue regarding giving the nonavalent vaccine. to people who've had the quadrivalent. It's just that as a public health policy measure, it doesn't meet the usual expected cost-benefit ratios.
Yeah. Dr. Brickman, do you have any thoughts on that?
I don't have too much more.
Okay.
Yeah.
All right. Well, then we're going to move on. We're going to move on from vaccines to PAPs. So there, and by the way, I got a small, not a question, but a little note of appreciation from Contra Costa County. They wanted to say thank you very much, wonderful presentation. So passing that along. In terms of anal PAPs, I have an attendee who wants to know if there are best practices to perform an effective anal PAP.
So we do, yeah, I'll take this one. So we do have practice standards, which I alluded to briefly. They're from 2016, and they're put out by the International Anal Neoplasia Society. And so one of the main thing from it is your rate of unsatisfactories. And I forget how much it should be, but it should be below a certain percentage. And if you are getting a lot of unsatisfactories, there are ways to improve upon that technique. And, you know, in one of the courses we offer actually reviews how to do that appropriately, but you know, it's actually pretty easy to troubleshoot. So I would recommend looking at those guidelines. And if you find that you're getting a lot of unsatisfactory, you can reach out to any of us and we could quickly troubleshoot that.
Great. And there's also
a small editorial comment, which is we don't actually use the term anal PAP because those really apply to the cervix. Our pathologist at UCSF regularly chops off our head when we say that. So the preferred term is cytology. We'll call it anal cytology, though patients often understand anal PAP better.
Yeah, thank you. Thank you for bringing that up. And then actually a very astute attendee asked, using the correct terminology, is swab anal cytology without HRA useful for screening in the absence of visible lesions? And what are your thoughts on that question?
Well, that's precisely the way it's used, actually, because that's the first thing we do. And the purpose of the cytology is to help decide who's going to be referred for or get HRA. Now, having said that, we in our clinic do it routinely as part of our exam too, but not for the same reason. It's not being used in screening mode, but rather as a quality assurance measure, because we know that when the cytology comes back showing a high-grade lesion, that we really should find it at the same visit where we're doing the HRA. And if we think that the exam is normal, but the cytology that we had done comes back a few days later showing high-grade disease, and it means we missed the lesion and we need to bring the patient back.
Yeah. And what do you, I'm curious what you two both think, or what piece of advice you have for clinics that want to start this anal cytology program, but they might not have a high resolution anoscopist available to them yet. Because as you said, Dr. Pilevsky, one of the real challenges of this now is building the capacity of our HRA workforce. So do either of you have any pieces of advice for clinics that want to start doing anal cytology, but don't have an immediately available HRA provider yet?
So you absolutely need an HRA provider. You cannot get abnormal results and then not know what to do with them. And you know, the proportion of people who screen positive, meaning that they will need HRA, depending on your population, has the potential to be really, really high. So either identify where patients will be getting referred to and confirm with them that they have the capacity for a certain amount of patients, or B, invest in training someone, which is, you know, logistically complicated for many reasons, but I think is probably the best long-term solution. And then as Joel mentioned, you know, if that's not available, then digital anal rectal exam to detect palpable cancers for treatment of the cancer is the alternative.
I would actually just reword that a little bit and say it's not the alternative, because everybody should get the dare anyway.
Yes, yes.
So we all know
But it
how
is
to
something
do
you
it.
can offer.
Yeah.
Yeah.
But Christina is absolutely right that we don't recommend doing the screening procedures unless there is a way to follow up on any abnormal results that may come by. But until that time, everybody, we hope, will get a digital anorectal exam.
And, we actually, this brings me to colonoscopies. So we've actually had two questions now about colonoscopies, which is if, first, if there is not an HRA available, could a colorectal surgery referral be an appropriate follow-up for someone with anal HSIL? So could we send them to a colonoscopist? And then another attendee asked, are anal cancer screenings or anal HSIL screenings included with your routine preventive colonoscopy screenings? So what do you two think about those two questions?
Unfortunately, I don't think those are good options.
Yeah.
Primarily because either the surgeon who's doing a colonoscopy or even a GI person doing colonoscopy are not usually trained in HRA, and they're going to pick up obvious things, obviously, when they're doing colonoscopy, but they may miss some of the more subtle findings of a high-grade lesion or cancer. So unfortunately, I don't think that's a substitute for sending your patient or to someone who's trained in HRA, and it's not part of the routine colonoscopy screening procedure.
Right. Okay, we have a couple minutes left and a couple questions left. So I'm going to jump back to the anchor study. There was one question about the participants who were transgender, wondering if they are transgender females, transgender males, or both.
Yeah, so about 80% of them were born male and transitioned to female.
Okay, great. And then another question that came up was, why are 16 to 26-year-olds more at risk? Is it more if it is male to male sex or just in general in terms of age? And I think that I think this question is related to at risk for HSIL and HPV.
It's just that when they're 16 to 26, they've accumulated more sexual experiences by that time, generally speaking, compared with younger people. And the more exposures you've had, the likelier it is you've had exposure to oncogenic HPV, and the likelier you're going to have a high-grade lesion.
Great. And okay, it is 12:45, so I'm going to close with one last question, which is, when are guidelines for managing HSIL coming out for people living with HIV? So what's in the pipeline? And if you are able to discuss that, great. If it is still a stay tuned, also great. But people are wanting to know.
Them and I. I'm on the horn with the person every other day to try and find out when they're coming out. It's stay tuned is
okay,
but soonish, I hope.
Okay, great. Well, people are on the edge of their seat, and this has been lovely, and thank you so much for your time and your expertise, and thank you to all of the attendees for staying on with us and for your excellent questions. And finally, thank you for the CAPTC for arranging this. And so with that, I hope everyone has a great afternoon. All right, bye.
Bye.